Today, we're going to spend a few minutes with Maxine. Maxine, for those of you who are of a certain age, understand that she is this very sassy woman who says what's on her mind. And she seems to do quite a bit of justice for our cause, is because we really do want people to say what's on their mind and to know actually when to speak up. However, we also know that as sassy as she is, sometimes that can be alienating in a medical setting. So this is a perfect presentation to share with people. It has light moments because Maxine, he just kind of naturally makes you laugh. But on the other hand, it is designed so that you can have a lot of interaction. And I'll get to that in a second about, well, this is what Maxine would say when she's speaking up at this critical time. But let's rehearse what you would say to have a productive conversation with your care providers, your doctors and nurses. When you have a moment after we meet today, you will find in your toolkit that there is what's called an audience interaction tool. And the audience interaction tool is something. I'm going to start my video for a second because I want to show you this. I'm sorry. Okay, you know what? I am not doing very well with this. Okay, can you all see that I have this? Okay, this is your audience interaction tool. It's in your toolkit. It is an illustration of Maxine and a conversation bubble. Before your presentation, you'll go to your kit, you'll cut this out and tape it either to a pen that maybe will have your company name on it, or if you don't have that, a straw or a popsicle stick. On the back, you can tape your business card. As you can see, I use Melissa's at Bridge, at the bridge, but hers is nice and vertical, but you can put yours on any way you choose. When people arrive, you want to have this in their seats or at their desks, because this is something that you'll use to help them rehearse how to speak up. And it's a fun icebreaker, and it's also very helpful because in effect, you're literally giving people their own voice, and they will remember the times that it's critical to speak up. So I'm going to stop the video again, and we'll dive right into it. The second slide in your deck is always dedicated to you. This is where you can insert your photo. It's your a thank you to your hosts for bringing you together. So it's a very nice thing to list their name and the organization if they have an event name. Oh, and the date, of course.
And we don't see any slides. All we can see is the actual page for the toolkit. There's no slides advancing.
Oh, okay. Thank you. Is it now? Is it advancing now?
No.
I don't see the screen now. I just see the gallery view.
Yeah.
Oh my gosh. Thank you for telling me that. What about now?
No.
No.
Okay.
It was just showing the same photo of Maxine. So
Right,
maybe you
'cause-
hadn't advanced to the next slide. Is that what it was?
Is it showing now?
No.
Okay,
Just
Karen,
the
if you want
gallery.
to give me sharing capabilities, I can pull up the slide deck. I just did it yesterday. And then I can be your clicker and then you can talk.
okay. As you can tell, this, I get really unnerved by the technical aspects of this. So let me figure out I love that idea, Deidre, and I will take you up on it. I have to figure out where I'm going to find this ability. Okay.
I think you were trying to show us the audience interaction exercise thing, right? Before, because we were only seeing that first screen that whole time.
Okay. Yeah. Okay. So you didn't even see that.
No.
Okay. Are we screen sharing now? Can you see it?
Yes. But now we
Yes.
see the next slide as well.
Now, there you go. I think it was just that you hadn't advanced to the next slide, correct?
No, I think I lost the screen share. Now are you seeing it?
Yes.
We see the
Yes.
welcome and thank you for coming
Okay,
screen.
thank you. Okay. All right. Clearly I need to figure out how to do this a little better, but please bear with me and thank you for your patience. So Deirdre, I can advance these slides now that everybody can see it. This is your thank you page that you get to customize and put all of your contact information on it particularly. Every deck has a second page with this customization for you. The third page is always a nod to the Care Partner Project. And there is text for just about every slide. And I'd like to emphasize that this is, please don't feel like you have to memorize the text. It's just a jumping off point. And you'll want to put this into your own words. Yes, it would be great if you kept the key messaging that goes with the graphics on each slide. But it doesn't mean that you'll necessarily cover all of the key messages. I like to tell people that when I create the text for a lot of these slides, it's probably too much information on some of them. And if you skip any of it, don't worry, nobody is going to know. Even for yourself, if you put down, say, well, I'm going to put this into 3 or 4 bullet points. If you only remember one, that's totally fine. Nobody knows but you. And that one piece of information for people is more valuable than having nothing, right? So whatever it is that you share is always of value. The next slide is always the agenda because people like to know what's coming. And the last bullet point really is that you're going to allow them a chance to share their questions with you at the very end.
Karen, your slides are not advancing.
Are you kidding me?
No.
I'm sorry. Let me share with I'm going to share with Deirdre.
The offer still stands. I'm waiting.
Okay, I just need to share.
Yeah, if you give me host capabilities, I can.
Yes. So how do I give you the host? I'm under more.
So when you go up, you click on my picture and those 3 little dots that's next to mute, I believe that's where you can give me host capabilities on your side. Like when you go over here to the Brady Bunch slide, where we're over here.
All right, I just said one participant can control the slides.
Okay, I think you have to assign the participant.
I clicked on you.
Okay. Still not letting me share. It's not letting me share.
Okay.
Or you can, yeah, I don't know, because I don't, if you're using Apple or not.
Can you see it now, the slides?
No.
Or they're
Oh,
not?
there you go. There you go. You got it. You got it now. Now they're going.
Okay, apparently it's just in that full screen view that I can't share them with you. All right, so we'll just do it in a smaller view. Okay, so here's the agenda. So the title is 10 times to speak up. And to speak up to help prevent infection means that you need to ask everyone to wash their hands before they ever touch you or anyone that you're caring for. And the reason for that is that studies have shown time and time again is that the number one way to prevent infection is hand washing. It's just that simple. So what Maxine would say is, hey, infection, not on my bucket list, wash your hands. This is a perfect opportunity to turn to the audience and say, hey, raise your Maxine and you tell me, this is pretty sassy. It might not win you any friends. So how would you ask for somebody, especially if it's a nurse or a doctor who comes in and doesn't wash their hands? That can be intimidating. So what would you say? And then you can start the conversation that way. If nobody speaks up, maybe you can start it off. I like to give Eileen Karina credit for the fact that the way she asks people to wash their hands when she is with a client or a loved one in the hospital is she brings in a whole bunch of those red Twizzlers, and she'll say with a little smile in her voice, hey, I'll give you a Twizzler to wash your hands. So bribery definitely works. But this is a good way to kick it off because infection, as you know, is a very big problem in hospitals. And if you can get that hand washing down, it'll go a long way towards preventing any potential complications that will keep someone in the hospital or maybe even kill them. Speak up to get the correct
Hi,
diagnosis.
Suzanne. This is Kathy Bowers with National Patient Advocate.
Kathy, could you put yourself on?
Thank you. Good job. You're just organized. You do well. You keep us going, and really appreciate your organizational skills or your speaking skills. It was very nice. Listen, I'm sorry to bother you, but I needed to get the right contact person. I'm not sure it was Curtis Sawyer. I left a knee brace. I put it on a chair when we were taking pictures with, what do you call it?
Sharon, can you mute everyone?
So hopefully somebody turned it in. Do you know who you have a contact person over there? Or?
Kathy Bauer, can you mute yourself?
Thank you. Thank you.
Does anybody have Kathy's phone number to? Okay.
No. You really, you keep it going. It's a hard job.
Sharon, I think you can mute everyone.
It's a really challenging job to, address a group like us. 954-821-0226.
Okay,
You're very kind, very, very kind. I appreciate it, and I hope you have a nice weekend. Thank you so much. All right. I will. Take care. Bye-bye. Bye.
I can't find the mute.
Kathy Bowers, turn your mute on.
Oh, I'm sorry.
Thank you. Okay. So the number 2 time to speak up is to get the correct diagnosis, because 1 out of 20 diagnoses are incorrect. And this is where you could insert that the Care Partner Project has checklists that anyone can follow to help make sure that they ask the kinds of questions to help them get to the correct diagnosis. Sometimes people will want to go and actually often, I think this is probably something that you recommend, is to always get a second opinion. So to have that set of questions means that you can compare answers apple to apples and help further, I mean, your own insight into a condition or your treatment options. So a diagnosis can also have implications like surgery or physical therapy or infusion therapy. And those kinds of recommendations also are part of getting to the correct diagnosis. The main question to ask, and this is at the top of all of our lists, are what else could I have? Doctors, there's a great book by Dr. Groupman called How Doctors Think. And this might be a good book to have on hand yourself. And it's really interesting. And he talks about the fact, and he, you know, as a doctor himself, he went through training, is that they're taught even more so to think in sort of narrow channels of thought. And as they get more and more specialized in their work, the less able they are and the less inclined they are to keep up with new information and learning outside of their area of specialty. So one good example, and you probably have many, is that if somebody has back pain, if they go to an orthopedic person, they're going to look at the possibility of that pain could stem from the bones. If you go to a neurologist, they will be looking at the neural pathways along the spine. And depending on their lens, they will have very different diagnoses and very different treatment options. So that's just one example. As I've said, you probably have many more. So to ask what else could I have is a start. And then also to think, oftentimes a doctor will say, well, I don't know what else you could have. But it's a good thing for everybody to keep in mind that there may not be just one answer to a medical concern. Speak up for alternatives to surgery. Now, when I heard this statistic a few years ago from a company that actually studies this, actually for employer organizations, that 40% of recommended surgeries are unnecessary, I was actually really stunned. And maybe this isn't new news to you, but there are so many potential other ways to treat a condition than surgery. But again, it means consulting physicians who may be willing to think out of the box, or to consult a number of physicians for alternative perspectives on a condition. But I think a lot of people too, and this is a good place to bring it up, is that physicians will say, well, you know, it's kind of routine, and there's only about a 5% chance of complications. But you know that if you're one of those 5%, it's 100% to you. And there is no such thing as having a risk-free surgery. Not only are there potential complications from anesthesia, but also from the experience of receiving care in a hospital, especially if that requires an inpatient stay. Another good thing to say, and this was actually a great audience interaction opportunity, is to speak up for plain speak. It's okay to tell your doctor you didn't go to medical school. And we all know how Maxine would say that. However, at this point, you could throw out some medical jargon like TPN, NPO. These are kinds of the things that often end up in notes on the whiteboard in a hospital room, where the nurse will come in the morning and say, okay, here are orders for the day, NPO. Well, who knows what that means? You know, I mean, patients shouldn't be expected to know. And so you can throw out like jaundice even, or PCP. A lot of people don't know what PCP is. And depending on who you are, you might think that they're talking about a street drug. Now that is really wild, but we just never know where people are coming from. But the main message here is to expect that medical care providers are to speak in plain language, because patients did not go to medical school and they need to remember what it was like to have conversations when they were actually in high school or middle school and use terms at that level. Another real concern is alarm fatigue. It is real and really dangerous. And you'll notice that we covered both of these last two slides in the Safe and Sound in the Hospital presentation. And I would like to say that even if you go to the same group with the same presentation and you cover these topics again for the second time, don't worry about it. We cannot have enough good messaging about these two key points: keeping it real with real language, and this very and one of the things that happens all too often is that alarms go unheeded, putting patients at risk. By alarm fatigue, we mean that a patient's alarms can be ringing and no one is responding. And how that happens is that all of us, most of us, I would say, have the ability that when we have a task at hand, and in this case, let's use the example of nurses who are at a nursing station and they're charting, and they have to really focus on getting their charting correct. Our brains have the ability to tune out ambient noise so that we can focus on important tasks. And this happens. It happens where the alarms will be going off for low oxygen uptake or blood pressure dropping, and on any floor there could be a couple of alarms going off at once. So not having attention for those alarms can put patients in real danger. So it's really important to speak up. And if somebody else's alarm is going off on a floor, it might not be for your loved one or for your client, but it's for somebody else and nobody's attending to it. It's really important to speak up and get attention for those alarms too. Speaking up about drug costs, Maxine would say, was this little pill costs how much? And we all know that when people cannot afford their drugs, they get skipped, or instead of taking it 4 times a day, people will take it twice a day in order to save money. Doctors have no idea what drugs cost. And just because they prescribe one, it doesn't mean that there isn't another cheaper version that's available. It takes a little work on their part, but as advocates, I'm sure you're happy to do that work if it means helping your clients lower the cost of their medications and to be able to take them. But people feel funny about bringing up costs because, as patients for years, we've been taught not to worry about costs, just to worry about getting better. But I don't have to belabor this point with you. The cost of care in this country is bankrupting people, and we need to start talking about the costs and how to control them. So I'll get off my soapbox. You may have your own soapbox on that, but that's the real issue here. Is in fact, this would be a good audience interaction exercise too, just because people do have such a hard time talking about bringing up costs with their doctors. Speaking up, and also, it might even lead to discussions about, is something that is, say I've got this drug that costs $300 a dose and its generic equivalent costs $30 a dose. You might want to have conversations with people about, quality. There might be some fears out there that, I guess I should pay the $300 because the one at $30 is just not quite as good. So it might lead to some good discussions about, quality, value, efficacy of drugs around cost. I may be taking a flyer, but I have a sense that there may be some perceptions out there that cost equals quality, not necessarily so. Speaking up for safe discharge. Now, this is a really good one, and a lot of people are not aware of this. Say that somebody is alone and they're worried and they know that they're going home. They're about to be discharged and there's no food in the pantry, no water in the fridge, or I guess it's always out of the tap, but just no ways to stay to stay fed or hydrated, no way to get to the grocery store to stock up, no one to help you. What if you're going home with bandages and there's nobody there to help change your dressing? It's okay to say this is an unsafe discharge, and that is the buzzword. This is an unsafe discharge. And when they hear that, they have to keep you in the hospital, and they have to put somebody in charge of arranging for support at home. And as much as anybody does not want to stay in the hospital for an extra day, it might actually assuage some worries if they know that there's actually an option, that the hospital is responsible for making sure that they're okay and supported at home. I think all of us have heard about discharges that are just kind of heartbreaking. I read a story a couple of years ago about a gentleman who was discharged from a hospital in Los Angeles to a bus shelter. He was unhoused, and so they felt that, I guess, that a step up for him would be to take him to a bus shelter, a bus stop that had a shelter over it. So you may have some stories of your own, but that kind of thing cannot be allowed to happen. Number 8 is to speak up about your patient status. All of these rules about the 2 midnight rule were dropped during COVID, but they're back. This is a really hard concept. So you go into the emergency room and they've given you a bed and even some privacy with drapes around it. And they've given you meals and they've administered medication and they're running all the right tests and doctors and nurses are coming in to see you. And then they even find a room for you. It's important always to ask, are you under observation status or admitted status? And the difference is that if you need follow-up care, particularly if you need any physical therapy or occupational therapy, if you have not been admitted, had admitted status for covering 2 days or 2 midnights, then your follow-up care will not be covered by your insurance. It comes out of pocket. And this is can be financially devastating. So it really pays to be the squeaky wheel on this. And in fact, this happened fairly recently to my cousin. Her mom was in terrible back pain and not getting better, and she went through the emergency room, and I just kept cautioning Holly, you've got to keep making sure that they admit her. Do not allow them. And she got pushback. In fact, some of the nurses didn't even know what she was talking about. So she escalated it. And she finally did get her mom into admitted status. And guess what? They discharged her about a day and a half later, 2 days later, just like under the wire. She just made it for this under the 2 midnight rule to a rehab facility, because that's really what she needed, was rehab for her back issues. So if it hadn't been for Holly being that squeaky wheel, they would have had to go out of pocket. Number 9 is speak up for safe surgery. These critical questions do make a critical difference. Does your surgery team use a checklist? Studies have shown that when surgery teams get together and they take a timeout, and this goes to the second point, it's a timeout to go over their checklist, meaning they say, this is the person we're treating. This is why, this is where we will be performing the surgery. This is the name of the surgery. It is on the left side or the right side. That outcomes are better. And then the third thing, obviously, is to make sure that everyone on the surgery team is board certified, including the anesthesiologist. It may seem like a small thing, but in fact, all three of these things, studies, as I mentioned, studies have shown lead up to better, safer outcomes. You know what? Another thing maybe I should add to this list is to make sure, does the surgery team introduce themselves as well? Because another part of the study showed, in fact, I'll change the slide, that a lot of people are not aware that when surgery teams come together, they may not know each other. And so by introducing themselves, even just a first and last name, it breaks the ice and makes for better communication that may be needed during a procedure. And then speak up for help. We get by with a little help from our friends. So, so as Maxine would say, hello people, could use some help here. This is a very good way for you to wrap up and say, and guess what? Here are lots of people who are ready and willing to help pitch in for patients. Just ask. You can ask kindly, and your friends and family, local service agencies, and professional advocates, of course. And then this is where you open it up for questions. And then a thank you, where you again restate who you are, where you're from, your contact information, put your headshot there. And then this is your chance to ask them if they would kindly remember you or suggest other groups that you can speak to on either Maxine or any other, or a number of other topics. Okay, so let me start. Let's bring everybody together again. So would you start your videos? Okay. Questions? I'm sorry for the bumpy start, the bumpy everything. And oh, everybody's on. I have to unmute you. Can you unmute yourselves?
Yes.
Okay. Questions about this? And did you all see this thing? So this is your handy
Yes.
audience interaction thing. So they could go home with a pen if you have pens done. They go home with your card. They go home with Maxine. Hopefully they'll put it on the kitchen counter and their spouse or kids will come and say, hey, what's this all about? So they'll be able to report what they learned from you. Okay. Any questions, comments, suggestions?
Thank you so much for this. I really appreciate it.
Oh, well, you're so welcome. I'm good. I think I'm going to re-record it to put the recording up because this was just too bumpy. So I'll put a better version in the toolkit.
Well, I'd just like to say again, this is Sue Wallace out of the Dallas-Fort Worth area. And number 7 about speaking up for a safe discharge. That was one thing that I had to advocate for myself when I was in the hospital in November, because my children were out of the country and I had a pretty severe surgery, like gangrene all over the gallbladder had COVID at the same time. Anyway, I didn't feel like I was able to take care of myself, or I just wanted to have somebody there the first night that I went home. And the doctor tried to discharge me the following day after the surgery. And so I had to advocate for myself to the doctor that I wasn't equipped to go home. No one, a social worker or a nurse navigator, had not come in my room to discuss my discharge with me. And so it happens. And so we need to be sure that people understand that they have the right to speak up. So.
And also I want to add that people are so scared. So I gave this presentation yesterday and it was really engaging. It was real fun and interactive. And the stories that I heard from people. So one lady had her mom had gone to the hospital and they were ready to discharge her mother and they would not listen. So that's when you have to escalate. You have to use words like, oh, well, if she goes home and falls, that's called a readmission, right? Other things about, I don't know.
You raise your glasses like
Yeah.
that.
Yeah. Yeah. So I want to make sure I got your attention. And just being able to say things like, well, she doesn't have a hospital bed at home. You have been having caregivers come in here and assist her out of bed. Her bed is 3 feet off the floor. So if she falls, that's a readmission, right? So how do we want to work together to decrease your readmissions and then make your surgeon stats look well? Because if she goes home and falls, and she doesn't understand her plan of care, and she doesn't have the resources, can we talk to the discharge planner? And if they don't want to listen, then can we talk to the hospital administrator? Or if they don't want to listen, can we talk to patient advocate? I know you got a patient advocate department, right? So should we call them and see if they can help us out? Oh, you don't have one. Well, okay. So just trying to get people
Glasses like you. We all need your glasses.
I have a different color for every outfit.
She does. She does.
When you were giving your presentation at the summit, you said that you had one personality, and what were the two names that you gave yourself? You were Deirdre, or what was the other person when you had to get really
she's been asleep for a long time. Her name is Shanae.
Shanae. That's her. You don't want Shanae to come out. No.
No.
So is this a little glimpse of Shanae when you put your glasses on?
Oh no. This is just Deidre. This is Deidre, just understanding that when you go in the hospital, they're thinking about your discharge when you're admitted. So, and that is true.
Yeah, we add that to our statements and people go like, what? Yeah, discharge happens at admission. So they're already thinking about ways to get you out of there. And then so many things go along with each of these slides. So I have a story for each slide. It just depends on who's in the audience. So a little trick that I do is I offer the audience to, depending on how large it is, I have them say their name and why they're here. So that helps me say, okay, what stories I'm going to use, because I have hundreds and thousands of stories. So being able to connect with somebody in the room. So like yesterday, we had a lady that she wanted to be, this was a great group. It's a Christian Women's Job Corps. So these women are starting over and they're doing things with their lives and they're getting job skills and things like that. But one, she said she wanted to work in a hospital. So what happened was,
go ahead.
When we got to the alarm fatigue, I was able to kind of use her to tell, working in the hospital, you're going all separate kind of ways. You're answering the phone, you're answering the call lights, you're talking to doctors, you're faxing, you're emailing, you're going to run errands, and then you got to listen to the alarms too. So it's about a team effort. It's not just the nurse, but as a patient or a family member, how you can be a care partner is to ask the nurse to explain, what do these numbers mean? And what do I need to see? And when do I need to come and get you? Because you may be busy. So I want to help out by being a care partner. That's what this whole presentation is about. We're trying to train people how to be care partners. So, just kind of using those, how they can become involved so they can speak up for themselves or the ones they love.
Yeah. You should be doing this training, not me. You're so much better at this. Yeah, I think you've done it more than anybody else.
Done quite a few of this Maxine moments.
I'm sorry?
I said she's done quite a few of the Maxine moments.
Yeah.
And she's quite good at that.
They love them.
It
They
seems to me
love
too
them.
that one of the benefits of these topics is that it generates conversation, and to get them talking amongst themselves, with keeping the roar down. But yeah, I think that's great because the more they talk, I think it sinks in more to them. Yeah.
Yeah, absolutely. So I wanted to show you, and I asked Deidre's permission if I could show you the evaluations that she got from yesterday's presentation. And honestly, all the tech problems I'm having today, I don't even want to go there. I had teed them up on my desktop here, but I can't. Bridge too far. But I think with her permission, I will send you guys a PDF of them because it's just so important to see that in the evaluations, what people are learning, what they're pulling out of it, but also how valuable it is, how they felt about this learning and about, every single person said, yes, this exceeded my expectations. They walked out feeling really good. And I don't think, and yes, kudos to Deidre. She's a great presenter without a doubt. But also the impact of the information. And it's actually, I would have to say, we've gotten so much great feedback. Deidre is the one who's the most conscientious about sharing it with me. I wrote her back and I said, I hope you're putting this on your website. I hope you're using these things to market yourself because it's a credit to the presentations, but also and how she's able to bring it to life for people. Real world examples, real world conversations. So, and in any event, I guess I'm kind of belaboring this point because I've been hearing a lot of people say that they stop short of actually giving the presentations because they feel nervous about it. But I think this is a perfect example of that you can have fun with it too and have, really feel good about how you can impact people's lives in just a very short period of time. So other ideas? Well, I'm here if you ever want, and there's a suggestion box at the bottom of the page. If you want to ever drop me a note, you think of something later. So, okay, well, I guess we're all about out of time. Let me know.
Thank you again. Thank you.
Thank you.
Thank
Thanks so
you.
much, Karen.
Thank you very much, Karen. That was
Oh,
great.
Thank you for
Thank
being
you.
with me. Thank you.
Absolutely.
Bye.
Bye.
Okay. Bye-bye.